I want to welcome everybody to Pediatric Grand Rounds. This is a very special Grand Rounds, and we're going to have a little bit of an extended introduction. So first I'd like to turn this over to Dr. Elias.
Thank you very much. When Dr. Parmeshwar asked me to say a few words about Dr. Sisk, I was more than eager to do so. Dr. Sisk and I first met in the early 1970s when we were both residents at Duke Hospital. I was a couple of years ahead of Mike in adult neurology, and Mike came along after his pediatric residency and did pediatric neurology residency. When I got here, there were only 3 neurologists in Roanoke, and we covered all 3 of the hospitals. And as far as I know, there were no other neurologists in all of Southwest Virginia. So we were very busy, and we recognized that we really needed a pediatric neurologist because we didn't feel comfortable with handling the complex pediatric cases. So knowing Mike from Duke and that he was about to finish the program, I sort of solicited him to come and look at Roanoke, and fortunately he and Pat and the children liked it, and the rest is history. There were a few things that impressed me when Mike first came. I think his ability to get along with patients and his empathy with patients and so forth, and of course his vast knowledge in pediatric neurology was very apparent. A couple of other things I think I'd bring to mind is that formerly there was a child neurology clinic that was over at the rehab across the street. It was state supported, an indigent clinic, and there were numerous pediatric problems there, including epilepsy. We were very fortunate when Mike came to join our group that he took that over and did for years. It was not compensated, and it was voluntary for Mike to do that. Another thing that I recall is that in the early 70s, there was almost an epidemic of Reye's syndrome, which is virtually gone now, and very difficult to treat. And Mike handled those cases extremely well, and children were recovering that Mike was in charge of, whereas before the outcomes were not as bright. In the years that we practiced, my office was at the front of our clinic building, and Mike was toward the back. And I recall that there was a constant stream of mothers and children going back and forth in the hall that Mike saw. And he and Dr. Wilson, Tom Wilson, must have seen no telling how many children from all of Southwest Virginia, because they were drawing from West Virginia and Southwest Virginia. In conclusion, I would like to say that I've always felt like I was very fortunate to have known Mike for a lot of reasons, and we're still friends and have breakfast together. And I think that Roanoke was very fortunate to get Mike because at the time we were practicing as 3 adult neurologists, we really were not prepared to handle the difficult problems. So I wanted to leave all of you, especially like house staff, with this poster here. And what it stands for is when you're in doubt, you wonder what Mike Sisk would have done.
We have one other person. For those of you who know, this is Carly. Carly's been with us for a long time.
Wow, to get me up here to stand in front of all these people, you have to be pretty special. I just want to say thank you. You have been one of my best teachers for the past 30 years. I especially appreciate the early years in the 80s when you took the time to teach the nurses on 7 West in the mid-80s. You would sit down and teach us about the quirky patients that would come in to see you, information that we would need that would be important 20 minutes or 20 years from then, at the time when my nursing cap was probably, my brain was thinner than my nursing cap at the time. So that information has been wonderful, and everything you've taught me all those years all along. I also want to thank you for the compassion that you've shown for your patients as the years have gone on. When you are in with your families and your patients, you have a beautiful gift to make them feel like they are the most important person in the world at the time when you are in with that patient, and that is just a beautiful thing to see. So I would just like to thank you for your compassion, your teaching, your friendship, and that eloquent charting that I so much enjoy reading every patient every time. And in your time off, to save you time for me calling you and everyone else in the medical community, I have a little project that I'd like for you to do in the next year or so. When I pick up this little device, I would like to say, "Hey, Sisk, I have a neurological question," and I would like to say in your voice, "Yes, Carly, how can I help you?" Enjoy your retirement.
You're so kind.
This is a very special day, and obviously we're introducing Dr. Sisk. Dr. Sisk is retiring at the end of the month, and he's chosen to give grand rounds today, which is a great honor. I will say, I'm here on behalf of Dr. Dunsmore. She had an engagement with the American Cancer Society that she couldn't change. It got scheduled long ago, so she asked me to stand in for her. So introducing Dr. Sisk today. Dr. Sisk has been a pediatric neurologist in Roanoke for 33 years. A lot of people.
About 43.
43. Oops, I did the math wrong. Sorry. And so when Vidya was organizing this, she got several quotes from different people, and people have already hit on many of the big things. But Dr. Wilson talked about how back in the day they serviced 3 hospitals, multiple pediatric groups. It was a lot different back then, a lot busier in certain ways. Dr. Kraft talked about managing children with Reye syndrome in the adult ICU with Dr. Sisk's help. When I think of Dr. Sisk, I think of a very gracious man. And in this day and age where we talk a lot about physician burnout, I marvel at Dr. Sisk because he's always interested and always, nothing's ever mundane with him. And he's, I don't think I've ever heard Dr. Sisk speak poorly of anyone. And that's a lot to say. Dr. Desai talked about remembering his lectures on what used to be called mental brain dysfunction, which is now ADHD. And she also talks about him being a guru in Tourette syndrome. So today the topic is Tourette's, and Dr. Sisk, it has been an honor and a privilege to work along beside you and with you, and I want to thank you on behalf of the Department of Pediatrics, on behalf of Carilion, and on behalf of the children of Southwest Virginia for their service over these 43 years.
Yeah, you're good. Okay, good. Well, it's hard to follow that, but I'll try. I've probably given Tourette's lectures since about 1976 or 1977. And I try to do it roughly every 3 years, particularly since the pediatric residency started to have the pediatric residents have an update in medical students every 3 years. There have been some changes in the last 3 years. When I was in my last year of training at Duke, I did neurovirology bench research for a year and ran a couple of clinics on the side. And going back to Dr. Elias, my wife and I had no idea that I would do anything other than most child neurologists of the age did, be an academic child neurologist. And it turns out I am at the end of my career. But Bill invited us up here. My wife and I were reminiscing last night. First time we came in the fall was actually a gorgeous day. You know how those of you who have been here for a while, how the foliage look in the fall. The second time we came back in the winter, it was snowing. And our kids said, this is where we got to come. In Durham, it didn't snow very much. When we did, it was just a big mess. And so I've been here ever since. Tom Wilson joined us 9 years later. Tom wanted to be here this morning. Some of you know he's recovering from surgery and was not feeling well. Been a valued colleague, as has Bill all these years. Many of you may not recognize Bill from his polysomnogram reports. Bill is still working hard and reads the pediatric polysomnogram report studies like no one else does. So let's go with Tourette syndrome. It was felt to be largely a psychiatric disorder until the mid to late 70s, and we're going to consider some history here in just a moment. Let's do a brief historical perspective. Samuel Johnson, those of you who are English majors like me will recognize him as this great, amazing a man in the 18th century. In Boswell's history of him, he gives an almost word-for-word account of Tourette syndrome in an adult, and apparently including the expletives, which he may have done anyhow, being a literary giant at the time. The first report, which I wasn't aware of until fairly recently, in the literature, and it's mainly French literature, was Jean Hard in France in 1825, case report of 10 of a peculiar neurological affliction, and it didn't go any further at that time. Go ahead 70 years, 60 years, and George Gilles Tourette published a study of a nervous affliction. Residents take note. He was a resident with Charcot at the time. He didn't even have his private practice. And Charcot, it could have easily been called Charcot syndrome. But he said, why don't you take this? And he did, and the rest is history. Amazingly, there was relative scientific silence until the 1970s, about the time I was finishing training. And we'll talk more about that. Let's talk briefly about pathophysiology. Honestly, it still remains largely unknown. Biochemical imaging and neurophysiological and genetic studies support the general hypothesis that TS is an inherited developmental disorder of neurotransmission. In fact, many parts of the brain are involved with functional MRI testing done on these mainly adult patients. Basal ganglia and inferior frontal cortex have been implicated, as well as obsessive compulsive disorder and attention deficit disorder, what we call the Tourette triad. Tourette syndrome, ADHD, and OCD. Very, very common in my practice. Tourette.org, for those of you who want to read more, is an amazing website. Everything from just wonderful information for parents, and also if you're really interested in digging deeply into this, it has links to a lot of the current research that's going on. The founder of that, interestingly enough, was a mother in Brooklyn whose son had Tourette syndrome, and she was very upset that nobody was paying much attention to it. She founded that website. I think I was almost a charter member, and been a wonderful source of information all these years. Let's go. We're going to see a 5-minute video. Pay attention to this, and we're going to talk about, this is from the Tourette syndrome website. It's a 5-minute video.
What are tics? Would you know a tic if you saw one? Hi, I'm Pearson. I'm 10 years old, and I have Tourette syndrome.
Hi, my name is Caleb. My name is Brianna.
My name's Emily. And I have Tourette's. But Tourette's doesn't have me.
I have Tourette's, but Tourette's doesn't have me. And I have Tourette's, but Tourette's doesn't have me.
Tourette's is one kind of tic disorder.
Tic
tics are involuntary movements and sounds that I can't control.
Sometimes you might not see my tics, but I still have Tourette syndrome.
Only 5 to 10% of people with Tourette's have swearing tics.
What I wish people knew about Tourette's is that we can't control it. It's not contagious, it's not life-threatening, and there is no cure. Motor tics are involuntary movements. Some examples of motor tics are
Forceful blinking, eye movements,
Facial twitching,
facial grimacing,
mouth opening, head shaking,
head jerking,
shoulder shrugging, arm movements, hitting, leg lifting, body shrinking,
vocal tics are involuntary sounds. Some examples of vocal tics are
throat clearing, sniffing, animal noises, blowing.
saying words or phrases,
apple, 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 pomegranate.
screaming,
Having Tourette's makes me feel good and bad. Bad because sometimes it hurts, and sometimes people think I'm just misbehaving. Good because it's just how I'm made and who I am.
I have Tourette's, but Tourette's doesn't have me. I have Tourette's, but Tourette's doesn't have me.
I got Tourette's, but Tourette's doesn't have me.
I have Tourette's, but Tourette's doesn't have me.
As an aside, I have Tourette's, but Tourette's doesn't have me. It was the title of an Emmy-winning HBO documentary 14 years ago. And the reason 13 years ago. The reason I'm so sure about that is the National Meeting of the Child Neurology Society was in Los Angeles happened to coincide with the birth of a premature granddaughter, Michaela, named after me, and she was in an NICU that wasn't nearly as good as ours. But she got good treatment, she did well. But I was planning to go to that meeting anyhow, but she came early. She came like 6 weeks early and is thriving and doing well now. But there was an invited symposium the day before the meeting for those of us, I think largely members of the Tourette Syndrome Association, that was probably sponsored by drug companies the way it was back then. And there was a premiere of that movie, the world premiere of the HBO documentary, hadn't been on HBO yet, was at that meeting over lunch. And one of the kids, they had several of the kids there, and if you go to, you can still get this on YouTube, one of the kids who was kind of the star sat beside me at lunch. And, but I've handed out hundreds of these videos. The Tourette Syndrome Association, until recently, made them available. They've got shorter things that are much better with modern technology now. But that was a very interesting thing for me. I'm going to go through this quickly because the video covered most of it. You look at the simple tics here. Eye blinking, and it should have throat clearing here, are the simple tics. Simple meaning you can define them with largely one group of muscles, not involving a variety of different muscles in the more complex tics. Motor tics that are complex are the ones that look weird to other kids. Children in early grades, from kindergarten to 5th grade, often will put up with anything with their classmates if they like them. And you know that from other aspects of childhood behavior disorders. Most of these children, when I see them, have either not been bullied or had that one boy or girl in every single class in the world who makes fun of people. I think that's part of our society, that there's always a child who will make fun of others. The ones that are most likely to get their attention are the complex ones, like a child standing up in class and twirling and then sitting back down. That's not going to be looked upon nicely by their classmates. The major motor ones, where these children have an impulse to get up and jump or hop. It's one of the fascinating things I've seen throughout my career is a lot of these kids, without really thinking about it, suppress their tics at school. And they come home in the afternoon, often go to their room, and if they have vocal tics too, the parents hear these loud vocal tics coming from their room. Over an hour or two, they get it out of their systems, and then they come back and they're okay. And that's often a part of the history that I take on initial evaluation, that can they suppress them without thinking about it, and it's very common. Vocal tics, as I said, as an aside, are the ones that get these children into trouble in school. I think there's much better knowledge in among our teachers now of various medical things that I see, from epilepsy, headaches, to Tourette syndrome, and but vocal tics do not do well in the classroom. Now, the child who is sniffing, usually, is Laura here? You first, because I can't find the reason for this sniffing. Everything's negative, and about that time they begin to develop maybe some eye blinking tics and other things, and the diagnosis become obvious. Sniffing and grunting. Humming is a very annoying one. Maybe it's because I had a daughter who hummed on all trips. Any of you have that? Whistling. Spitting, of course, is totally socially unaccepted in our society. That's not a good one. Squealing, clenching the teeth is a very, very common one, too. Complex ones are stuttering. I've seen a number of kids who have been referred. I remember one girl from a number of years ago who was referred because no one could find a reason for her acute onset of profound stuttering. And it turned out that we did the full evaluation, couldn't really find anything either, and I think on the follow-up visit doing this, and actually treatment of that resolved her stuttering. after she had gone through 2 or 3 speech pathologists. Echolalia is annoying. All children developing speech echo their parents, but when it persists at age 7, 8, or 9, it can be a real problem. Palilalia, I find, is more common in Tourette's than echolalia is. These kids often say things over again under their breath, usually in short phrases. And again, on a car trip, that can drive parents crazy. Often the palilalia, in my experience, is very quiet, so it may not be a problem in the classroom. Coprolalia, of course, is what got Tourette's into the national news probably 25 or 30 years ago because of some profound cases of coprolalia, and it's actually very uncommon. Probably between maybe 5 or 10% of patients with this ever have it, and when they do, it's more often develops in adult life. My most dramatic case of coprolalia was actually coprophagia, which means showing the finger, which is obviously totally socially unacceptable. This wonderful guy who actually followed for 30-something years, people in the office will remember him. I last saw him about a month ago with a very cheerful goodbye, and he, in high school, was from Narrows, small community, small classes, and in the classroom, he would, sweet kid, just the most marvelous kid on the planet, but he would walk up to people and do this. And so he himself came up with a solution. He came in one day just smiling and happy, and he had taped his fingers together. And so anytime he was out in public, he taped his fingers together. Went away in his 20s and it's never returned. And he probably to this day was the most complex patient with Tourette syndrome I've ever seen. It was largely a treatment failure, but he still kept coming to me. I sent him to Dr. Harvey Singer at Hopkins, whose name you'll see on one of the slides, who's probably the world's expert. Harvey's just recently gone part-time. I think we're the same age. And he ran the first Tourette clinic in the world, as far as I know. And I sent him to Harvey, and he said, good luck, because we'd been through everything we could think of. Stop me at any time, by the way, if anyone has questions. Diagnostic criteria, we're going to look at 2 different ways, 2 different criteria. They're pretty much the same. This was a consensus statement by the Tourette Syndrome Classification Group about 5 years ago. Onset before age 18, multiple changing motor tics, 1 or more vocal tics. Tics evolve in a progressive pattern over time, and the big one, symptoms wax and wane. Duration longer than a year, no known precipitating illness, and observation of tics by a knowledgeable person, which in pediatrics is not generally a problem. DSM for 5 criteria, this is a slide I had to update. It hasn't really changed that much, but it's actually gotten simpler and easier. Both multiple, and you'll notice the similarities between the 2. Both multiple motor and 1 or more vocal tics, though not necessarily concurrently. Tics may wax and wane, but have persisted more than 1 year. Now, is anything magical about it here? No. I mean, I see kids 2 months into tic disorders. I know they got Tourette syndrome, but we don't. But I tell parents we do not use that term. We talk about transient or chronic motor or vocal tic disorders until a year, and then you can use the term Tourette syndrome. Something that may be a little bit in debate is onset before 18 years. Does 18 years one day make a difference? Probably not. I've seen very few onsets after 15, but I have seen a few, and they tend to be sometimes more complex patients. Disturbance is not due to physiological effects of the substance, such as cocaine, or general medical conditions like Huntington's disease or post-viral encephalitis. And the rare ones I've seen like that have been pretty rare. Affects boys 3 to 4 times more than girls. That has been true in my practice, and sometimes I think it's even more than that. Another clinical aside, there was a Virginia Tech professor who is Korean, who I saw his son, this was probably 25 years ago, for classical Tourette syndrome. He was doing great on the treatments we'll be talking about later. He said, oh, by the way, I think my sister has this. His sister was a traditional dress designer in Seoul, Korea. And she came over to visit, I saw her, and working with her family doctor in Korea, I got her on treatment, and she saw me once a year for several years and was doing well. So that's my most distant referral. Involuntary with limited capacity to suppress. One of the key questions, and as you get to know these kids, maybe not so much on the first visit, is can you make your tics go away? And most of them will think about it, say, you know, now that you think about it, as I mentioned earlier, I seem to do better at school, and I have to, quote, let it all hang out. I've heard that phrase many, many times from kids over the years. And this limited capacity to suppress is often associated with a very, very deep sensation that they just have to let the tics go. It's an absolute obsession that they have to let the tics go. And, but they often can do it and still do academically okay. A mean age of onset is 6 to 7 years, and that's certainly been my experience, although I've seen them as early as 3. 2% of general population is probably a bit of an overcall, but this is from the Tourette Syndrome Association information. I often tell people that if you go into any elementary school in the country and look at maybe 2nd or 3rd graders, about 1 out of every 60 or 70 will have it. We'll have not necessarily full-blown Tourette's, but we'll have chronic motor or vocal tics. Incredibly common. I have no idea exactly how many patients I've seen with this, but I think it's approaching 3,000 or 4,000 over my career. And I'm leaving to Riley and Dr. Daba about 200 active patients, I think, hopefully in good shape. Transmission. Genetically transmitted by autosomal dominant gene with extremely variable penetration. One of my absolute classic things I see is if both parents come to the appointments, Dad is sitting over there giving the history and says, nobody in our family has tics. Unbelievably common, unbelievably common. And one of my current active patients from Lynchburg, a wonderful family, his mom is actually from Romania, extremely brilliant woman, I think memorized the Tourette's literature, and they sit there saying nobody has tics, and the dad's sitting over there doing this. Roughly 50% chance of passing the gene on to children, but extremely variable penetration, and it may express itself as TS, a milder tic disorder, ADHD, or as obsessive compulsive disorder with no tics at all. Of course, that's not Tourette syndrome. In some cases, it may not be inherited and identified as sporadic TS. The cause in these instances are unknown. There's a sidebar a number of years ago with some, I can't remember her name now, a wonderful research neurologist at National Institutes of Health, Margaret was her first name, who published a series of papers that define what we now call PANDAS, Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep. She actually rescinded those papers later on. She said, I'm not so sure this is a real thing. I have no question, as most pediatricians in the group who've had a number of years' experience, sometimes strep does kick off tic disorders. Whether or not it turns into full-blown Tourette's is something that may or may not occur. If you want to read about that, it's fascinating, but I'm not going to mention more about that right now. The frequency of comorbidity in the TS population, hands down, the most common comorbidity is DSM-5 criteria of ADHD, usually of the combined hyperactive impulsive type, but sometimes the sneaky type, particularly in girls, as all forms of ADHD are in girls. OCD, which can really drive the family crazy. OCD by itself is difficult enough for families and kids to deal with, but you put it on top of the ADHD symptoms and motor and vocal tics, it can become a real problem. This is when I often turn now. I didn't so much in the past because they weren't here. I turn to my psychiatry colleagues to help out with what's the appropriate treatment, and we'll come back to that later. Anxiety disorders. What kid doesn't have an anxiety disorder in our society? Usually not so much clinical general anxiety disorder, but just a part of happily, some of the treatments we use can be very helpful with anxiety disorders. Mood disorders, kind of the same. Academic difficulties, I'd say in my practice it hasn't been 50%, more like 25 or 30%. Also, if we treat their tic disorder, treat their OCD, treat their ADHD, the academic problems go away. Those statistics are from my friend Harvey. What do these three things have in common? No biological tests for any of the above, although that may change in the future. Evolving childhood, standard diagnostic criteria used, all have DSM-5 criteria. Impairment defines the condition. Boy, how often can we say that in pediatric medicine? The impairment defines the condition. Diagnosis and treatment take time. You're not going to get these kids usually better overnight. It takes time and patience. Families come in wanting a cure for their kids, and it takes time and patience. Particularly with this disorder, the first do no harm criteria apply. Let's look at some common obsessions and compulsions. I'm just going to pull all these out here. Need for symmetry and perfectionism. I think all 8 of my grandchildren, lined up cars when they were kids. I think there's a little OCD on my wife's side of the family. And the need for symmetry and perfectionism. These are the boys who you go into their room and everything looks perfect, which is not normal for a boy. And it can take. Those of you who have read a lot about OCD, and I think, practically anything can occur with obsession or evening out, neatness, counting rituals. If there was an OCD kid in here now, they probably wouldn't be paying attention to me. They'd be counting the tiles. Or those of you who are churchgoers, if you have a pipe organ that counts the pipes, they'll be able to tell their minister how many pipes there are on the pipe organ. Checking things over and over. Going to bed. You sure you turned the lights off? Are you sure the windows are locked? And that's not a paranoia. It's actually part of OCD and constant doubt or worrying. Are you going to die in your sleep tonight? Had I better sleep in the room with you tonight? Germ obsessions, oh boy. Look for chapped hands. And no more said about that. Ritualistic behavior. Obsessions, as you know, are intrusive and recurring thoughts and images, and compulsions are irresistible urges or impulses to repeat ritualistic acts over and over and over again. OCD waxes and wanes, just like Tourette syndrome, and exacerbated by stress, just like TS is. Psychoeducational assessment, I'm going to go through this really quickly. And the kids who are having academic difficulty, full child study evaluation and perhaps a referral to a clinical psychologist or a neuropsychologist in selected cases. It's pretty easy now in our whole referral area. A short letter from me gets child studies done. That was not true even a few years ago. Academic concerns, difficulty organizing. Despite the OCD, they may have trouble organizing their schoolwork. Difficulty playing quietly. Excessive talk. These kids will often talk your ears off after they get to know you. And interruption and intrusion, which again, all kids do, but these kids can sometimes do it with a passion. Does not appear to listen. Again, what makes that abnormal? Often loses things. This is the DogateMyHomework kids. The mother will know that it's in their book bag. I see some smiles, maybe other kids do that too. And they'll get there and somehow never makes it to the teacher's desk. Engages in physically dangerous activity without considering consequences. This is the kid, the younger ones, that you want to hold their hands when you're in a parking lot. The whole variety of learning disorders can occur in this. Anxiety disorders. These kids have poor concentration, poor general organization. It may be due to transmitters and not just with the worry about tics, and that's a point of research interest. looks like ADHD but is not and requires different treatment. Again, I lean on my psychiatric colleagues for this. Mood disorders, depression is pretty common, particularly in older kids. And it's usually correlated with the OCD or ADHD and varies with tic severity. Rage attack, the DSM-5 now calls that intermittent explosive disorder, is not uncommon in these kids. They lose temper, particularly if they had a bad day at school, and they come home, somebody's bullied them, they don't want to tell their parents about it. Having a daughter who was bullied in middle school at a private school in Roanoke, resulting in her changing of school. I can appreciate this. Joanna, by the way, had an article as an adult called Bully in Cricket magazine. Maybe you may be familiar with that children's literary magazine, that with permission from the publisher, and Joanna is now being used as a teaching tool in our child psychiatry division. She did fine. Probably due to complex urge resolution. Child will usually be remorseful, but not able to explain, I don't know why I did that. Quick temper, overreaction, mood changes. These kids can be very difficult for parents to live with. Oppositional behavior and defiant behavior. Okay, I wanted to be sure to have plenty of time for this. Let's look at treatment options for TS. Perhaps if you can afford it, if you have someone in your community who can do it, one of the best non-medical approaches, or sometimes combined with medicine, is comprehensive behavioral intervention for tics, or CBIT. You know, is anyone in our community doing CBIT now? Noah? I didn't think so, yeah. Combines habit reversal training and cognitive behavioral therapy. Unfortunately, insurance does not cover this well, even with the diagnosis of Tourette syndrome. But there have been some great reports out of the University of Minnesota, I think Stanford, showing that if you can get families and the child really involved in these intensive one-on-one therapies, often it either eliminates or reduces greatly the need for medication. Very effective short and long term, but many practical limitations. And there's a great patient brochure about this on Tourettes.org that I'll have to give to families when they come in for a first appointment. We're going to discuss medications. Alternative therapies, believe it or not, Botox injections are used. Where would you think Botox injections would be used in Tourette? Neck and vocal cords. People with absolutely profound, socially disabling coprolalia in adults, obviously only. There have been some reports, I forget where it's from, on effective use of Botox without really interfering with the voice. I don't know quite how they do it, without interfering with the overall voice, but there's some pretty good reports on that. Understanding and support from peers and adults is extremely important. Okay, let's look at the medications. Alpha-2 adrenergic drugs change the face of our treatment with Tourette's. This was first reported in the early 80s by Dr. Singer at Hopkins and a group at University of Florida, Tampa campus, and it was done purely. It was not done on a scientific basis. It was done on, let's just try. We tried everything else. Let's try alpha-adrenergic blockers. And guanfacine in a lot of patients is absolutely magic. Clonidine, I use less than guanfacine because it tends to be more sedative. Both are available in single and divided or single time release, and it's just remarkable. I've had kids who I'll see on a Thursday start guanfacine on a Friday, and the parents call back on Monday and say, how did you do that? And just one of the most dramatic responses you can see in some of these kids. But most of the time, I start with a tiny dose and then titrate up. And the time release, the one problem with the time release, and I may have this on a later slide, is that it's very hard to get it through insurance. They've recently become generic, and we're having an easier time doing that. But you know, Cap-Bay is the time release clonidine, and Intuniv is the time release guanfacine, and you can give those in the morning without sedation in most patients. You probably know that they are only FDA approved for ADHD treatment as an alternative to psychostimulants. And again, often if I go through the hassle of getting a drug approval, I can get it approved. but sometimes it's a hassle to do that. In the past, haloperidol, pimozide, risperidone, and others were commonly used, rare now because of side effect profile. That is what I used probably my first 10 years of practice. That was the standard of care. Pimozide was developed in Europe, and it is FDA approved for Tourette syndrome. But you have to follow the cardiac function. It can cause problems with rhythm, and I think I have 1 or 2 active patients who are teenagers that nothing else controlled. I've still used Pimozide in. Risperidone is essentially never used for tic disorders now, and haloperidol is there for maybe historical interest. It's still around, but I probably would never use it for Tourette syndrome. How about treating comorbid ADHD? And this is often what gets the kids in academic problems. If used carefully and immediately stopped if the tics worsen or the side effects occur, both the stimulants, methylphenidate and mixed amphetamine salts, can be very effective and well tolerated. Also, the non-stimulants such as atomoxetine and the time release, guanfacine and clonidine can be safely used. Paradox. And this is what I was referring to earlier. Only FDA approved and sometimes difficult to obtain insurance, but I hope now with generic. Essentially, when things go generic, they don't give you any trouble getting them approved. Comorbid OCD. My child psychiatry residents have been wonderful in helping me with this. One of the things I've enjoyed most of my 9 years here is being privileged to help train 15 child psychiatry residents. They spent 6 months of Tuesdays with me, and I learned as much from them as they learned from me. And matter of fact, I think 5 of them are in the general area now, which is what we want our residency programs to do. And they keep me up on the stuff that's going on. It's really interesting. I've noticed in the last few years, they're not using the fancy brand name drugs. They're going back to the older ones like fluoxetine, sertraline, citalopram, and generic Lexapro. And often between one of these drugs, we can usually help their comorbid OCD without aggravating their tics. Clomipramine, tricyclic, I used that a lot before the SSRs came along, and it's one of the 6 of the tricyclics on the market. Clomipramine is FDA approved for OCD, and so it's really easy to get it approved if you use that diagnosis. It's got the advantage of giving it night only. Kids have sleep problems; it'll help them sleep, and it's before the advent of SSRIs, it was a drug of choice because it's a significant serotonin uptake action. Before I go on to some personal comments, any questions from the audience about any of this? Anybody? I don't think I was that thorough.
I have a kiddo.
Hold on. Oh. You're always on the other end. Got to speak for the big audience.
I have a kiddo who I do think has PANDAS and who's having rage.
You messaged me about him, I think. Okay. Or Tom, maybe. Doesn't matter.
Yeah, maybe. And who's having rage attacks out of the blue. Have you seen that associated with PANDAS?
Some of you who have been around for a while remember Dr. Gary Stewart, who's an absolutely wonderful pediatrician at Reed Hopkins group in Lynchburg. Gary called me about 7 or 8 years ago. He's retired now, saying, "Mike, listen." And he put the phone up to this kid, and he was screaming, shouting, throwing stuff in the room. And he said, "What should I do?" And I said, "Well, let's get a strep culture. Let's get anti-DNase B antibodies." And it came back off the chart. And we treated him with a month of high-dose penicillin or amoxicillin, treated him with guanfacine, and 2 or 3 months later it was gone. He was probably the most dramatic case I've ever seen. I think PANDAS may be real, but I think it's very rare. But if you have those high anti-DNase B antibodies, which are like 10 times normal, you know, I think you should treat them, even if they have negative strep cultures, you should treat them. Is that what you're doing? Good. Didn't work. No, well. Yes.
Mike, can you comment on stimulant medications and their effects on motor? Stimulant medications and their effect on motor?
Going back to my slide, until probably 15 years ago, I'm not sure you remember this, it was absolutely no-no to give anybody with tic disorders psychostimulants. Then some work done again by Dr. Singer and his colleagues and some others said, gosh, we just got to do something with these kids' ADHD. And so they started with titrating extremely low dosages of the methylphenidate and/or amphetamine salts, and find, hey, my goodness, it's not increasing their tics if used carefully. And I must have treated 1,000 kids with adding stimulants to that. You have to watch, and if their tics immediately get worse, you've got to back off. But the instance of causing tics, increasing tics, is pretty rare.
Any other questions in the room? We've got, all right.
This is our new colleague, Dr. Daba, who's official today.
I'm about to Daba.
Everybody clap.
So I'm about to Daba, the new pediatric attending, the neurologist attending here. Thank you, Dr. Sisk, for a great overview about Tourette syndrome. Just your opinion about probably you are going to talk about it. What's your thought about DBS for Tourette syndrome? I don't know if there is anyone.
Deep brain stimulation.
Yeah. Just your
may have a place. I know there have been reports. It'll be interesting to see a bill if your sons work on at UVA with transcranial directed ultrasound. May have a place for this some way. It's kind of hard to imagine doing DBS on somebody who didn't have really profound. But I actually don't have an update on that.
Any other questions in the room? Real fast, I'll unmute the phones just in case we've got a large crowd. You're a popular man. All right. If you're on the line and you do not want to ask a question or make a comment, please just place your phone on mute now.
The conference is now in talk mode.
Okay, does anyone on the line have a question for Dr. Sisk or want to make a comment really fast?
No barking dogs in the background.
No barking dogs? Going once, going twice. Anybody? Okay, I'm going to put the phone back on mute.
The conference is now in silent mode.
Questions? Part of this. Which of the following best describes the Tourette triad? A, motor and vocal tics, anxiety disorder and OCD, motor and vocal tics, ADHD and OCD. C, motor tics, mood disorders, and ADHD. Goes for number 1 for A. B, at the whole room. Second question. Most experts feel that the following approaches have a place in Tourette syndrome. A, CBIT. B, alpha-2 adrenergic drugs. C, typical and atypical antipsychotic drugs such as haloperidol, pimozide, and risperidone. That's a little bit of a tricky one. All of the above? It's B. It's A and B. A few years ago, a past iteration, number C would have been in there, but we rarely have to go to that now. Okay, you guys covered a lot of my career really well, but I just have a couple of personal asides. A look back. Most at the top of my list is husband of Pat for 55 years. She put me through medical school and residency as a high school biology and chemistry teacher, and happily all 3 of our adult daughters are teachers, and I couldn't be more proud. Father of 3 daughters and granddaddy of 8. 2 birthdays this week, one 22 and yesterday one 11. Oldest granddaughter is in graduate school in something I had to look up, linguistic anthropology at the University of Texas, Austin. MD for 51 years, 43 years at Roanoke Neurological. As an aside to Dr. Ackerman, I can't tell you how honored I am for you to come today, Alice. Alice interviewed me at a Starbucks. And things were going on in my practice life then that I was discontent with, and I was looking for a change, and man, it's just been, the last 9 years over here have been absolutely amazing. 34 years as a member of Roanoke Neurological Associates, and 9 years over here, and I've just been honored to be here. Real quickly, how's the field of child neurology changed during my career? Man, neurology has gone from largely an observational specialty to a treatment specialty. Bill mentioned the Rye syndrome, which took a lot of my time. First 8 or 9 years of my practice, I would spend the night in the old wasn't a PICU then. It was just a adult unit we put kids in. One of the early treatments for that, we didn't have a neurosurgeon in town doing bolts, monitor pressure. I put in catheters through an LP and hooked them to a manometer using very careful sterile technique, and monitored the pressure, making it go up and down with infusions of steroids and mannitol. I treated about half a dozen kids that way, 15 cases, 1 death, and the mortality rate at that time was 40%. My favorite memory of the Ride syndrome is these kids were in the unit at the same time. One was a guy named chickenpox epidemic, and I thought they both were going to die. They were incredible. Today, I still get Christmas cards from one of them. One is a practicing internist in Charlotte, and the other is now a lawyer, full partner in a group in Richmond. All my cases didn't do that well. Electroencephalogram has been important to our practice. I introduced ECS criteria in the lab here, and with the help, remember Perry Hope? There was a wonderful technician at Duke that we hired to come up here and revamp our office and EEG. My last year of training, in addition to doing neurovirology 6 hours a day, I read EEGs in the morning starting at 5 o'clock and read probably 2,000 EEGs at Duke. And you go back to the end of the day and go over them. And so EEG has been an important part, it still is. Epilepsy has gone from 4 medications, phenobarbital, dilantin, primidone, and bromides, which you may not have heard of before, to more than 10 now. Our success rate in successfully treating epilepsy has just skyrocketed in pediatric epilepsy. Happily, a lot of these kids have self-limited epilepsy that goes away with age. So we've been very fortunate there. And headaches, an important part of our child neurology practice. And I think Tom Wilson and I do as well as anyone in management of pediatric headache. Again, using low dose of safe preventative medicines or appropriate rescue medicines. And cutting edge right now is changes in the treatment of Duchenne's muscular dystrophy and SMA. If we had time, I'd have Emily talk about that. Bill, you may not be aware of this, but Dr. Stanapel, our wonderful head of department at Duke, by the way, he's only 6 years older than me. Weird. Stan is 83 now, and head is still emeritus head of neurology at Houston Methodist Hospital, and he is doing this amazing work with leukapheresis, where they take out large amounts of blood, separate the plasma, remove regulatory T cells, and which are defective in many cases of ALS, and insert and then give it back to them. And they have three patients now who are 1 year without progression. Incredibly, who knows? Maybe it won't pan out, but you can actually go on the internet, on YouTube, and watch Stan. He still wears a bow tie. I think that's it. Amazing colleagues. Most of my office staff is here today. And my dear Tracy, who's been with me since a month after I started over here, world-class RN, as is Carly. And we've been blessed with a family atmosphere there. We really have a family atmosphere. I think everybody, I still love coming to work every morning. And after 5 days, I won't be doing that. But it's been quite a ride, and I thank you all for your attention.